Good morning. My name is Dr. Spencer Schaller of Internal Medicine at Massachusetts General Hospital, and I am working alongside my colleagues, Dr. Kate Kirwood, also of Internal Medicine, and Dr. Erin Dustin of Endocrinology. And today we are presenting to you a case of a 54-year-old male with a sudden cardiac arrest. Next slide, please. I'd like to start with the sample history of the patient at initial presentation to emergency medical services. The patient presented unresponsive to EMS, and upon further investigation, no pulse or breathing were present, and thus EMS initiated cardiopulmonary resuscitation. The heart rhythm was identified as ventricular fibrillation, so 4 shocks were delivered. Allergies, medications, and past medical history were all unknown at this time due to the patient presentation and being unresponsive and a lack of information from bystanders. The patient had been eating lunch, or as reported by bystanders, eating lunch at a fast food restaurant prior to EMS arrival on scene. And bystanders state that the patient gasped suddenly with full body shaking and loss of consciousness. The shaking movements ceased quickly, but he remained unresponsive. EMS was able to achieve ROSC, or return of spontaneous circulation, at a slow, wide, complex heart rhythm with a rate of 40 beats per minute. However, reportedly, there was a concurrent return for mental status, but CPR had to be resumed after pulselessness reoccurred. Next slide, please. Thank you. Next, we're going to talk about the interventions that EMS was able to perform and that we performed in the hospital at initial presentation. The patient arrived at the hospital 30 minutes after the initial arrest, 30 minutes post-arrest. EMS had completed the following interventions at the time of presentation in the ER. They had initiated CPR. They had delivered shocks for ventricular fibrillation. They had given intravenous naloxone, amiodarone, and epinephrine per AHA guidelines. Upon presentation to the ER, the patient was unresponsive middle-aged man who had undergone mechanical CPR via EMS and had no external signs of trauma. Intravenous calcium chloride, dextrose, and insulin, and sodium bicarbonate were administered. In addition, vasopressin, norepinephrine, rocuronium, and ketamine were administered intravenously, and aspirin was administered rectally. Emergency intubation was performed, and an orogastric tube, a femoral artery arterial catheter, and a femoral central venous catheter were also placed. Electrocardiograms were obtained on presentation, and after the return of spontaneous circulation in the hospital, they show uncertain atrial activity, a regular accelerated idioventricular rhythm at a rate of around 70 beats per minute, with a very wide QRS complex and multifocal premature ventricular contractions. These can be shown by the white arrows, which you may or may not be able to see to the right on the top image. Also of note is the presence of U waves, which are shown by the black arrows. There's a before and after ROSC EKGs shown in the top and bottom. A CT image of the head was also obtained without contrast, and it was revealed to be normal without any evidence of infarction, intracranial hemorrhage, or mass lesions. This can be seen in the bottom left. And then you can also see images from the left coronary angiogram in the bottom middle and the right coronary angiogram in the bottom right. They only show minimal irregularities and can be considered insignificant for this patient. Due to cardiac arrest and the cessation of oxygen and proper perfusion to the brain for extended periods of time, a neurology consult was completed. A repeat examination performed after the medications used for sedation was discontinued and revealed unequal pupils and sluggishly reactive pupils. The left pupil was 7 millimeters in diameter and the right was 5 millimeters. Corneal reflexes in response to noxious stimuli were absent. These results signify that there is something wrong with the patient's brain and neurological impacts. Further blood tests reveal a 2-fold increase in white blood cell count, and on part of the patient's liver had begun to shut down, causing liver cells to leak enzymes into the patient's blood. Muscle proteins were also found in the blood. At this time, hepatitis C was one of the things we expected to be the cause of the problems, but due to the recent cardiac arrest and lack of oxygen and thus perfusion to organs for extended periods of times, we ruled that out and expected that to be the cause of the liver failure. Treatments prior to diagnosis. Prior to a diagnosis being made, medical staff completed the following procedures and gave the following treatments to the patient. Intravenous amiodarone was given to combat irregular heart rhythms, as noted in the previous EKGs. And in order to counter the low blood potassium level, potassium chloride was infused via IV initially at 60 millimolar, then an additional 40 millimolar, and a final 40 millimolar infusion was needed to be given. Due to the additional information collected from the patient family and friends, which we'll hear later on, a diagnosis was eventually able to be made after these initial interventions. The patient family reported that there was no history of chest pain, dyspnea, or symptoms of heart failure or dysrhythmia within the patient. They also reported that he had a poor diet consisting primarily of several packages of candy daily, and that they also stated 3 weeks earlier he had switched the type of candy he was eating. They also said that he had no contact with any sick individuals, didn't have any reported fever or chills, nausea, vomiting, or diarrhea. Medical history included a previous heroin use disorder and untreated hepatitis C virus infection. The patient had never had any adverse drug reactions. It is important to note that the patient did work in construction. He did not drink alcohol, but he did smoke about a pack of cigarettes a day for the past 36 years, as reported by his family. And he had reportedly been abstinent from opioids for the previous 3 years. And the family reported no family history of cardiac, respiratory, renal, neurologic, or endocrine diseases.
You said candy? I'm sorry.
Sorry?
I'm sorry. You said candy? He eats nothing but candy?
Yes.
Wow. Okay.
Patient's family did share that he is an avid candy eater, and he eats many containers to even pounds of candy within the period of a day. Patient's family also shared that 3 weeks prior, he switched from gummy candies to all-natural licorice. They also state that the patient complained of pain in their calf and other muscles for a period of a couple days prior to presentation, and that was initially overlooked by the patient's family as they assumed it was related to his occupation as a construction worker. I'm now going to pass it off to Dr. Erin Dustin.
Thank you. So I'll first be speaking on the chemical similarities of drugs that can induce the apparent mineralocorticoid excess. And so the notable aspect of each of the increasing number of compounds that can induce apparent mineralocorticoid excess, as shown by the compounds on the screen, is that they're chemically similar to one another and also to aldosterone. And so depicted here are the alglycone components of these compounds, which are all congeners of the 21 carbon serol. And so it's not difficult to imagine that each of these compounds could create an acquired apparent mineralocorticoid excess by binding to and also activating the mineralocorticoid receptor and other critical receptors in the pathway. And in fact, this chemical similarity could well be used to predict the potential of emerging compounds to induce apparent mineralocorticoid excess. And so due to the glycyrrhetinic acids that are similar in shape to cortisol, it's able to bind to the same enzyme and prevent cortisol from breaking down, which causes the cortisol to accumulate. And this causes problems within the patient. And I like to note that cortisol in this glycyrrhetinic acid has 100% or 100 times more affinity for the mineralocorticoid receptor than aldosterone. And as a result of this forces a stronger effect than aldosterone, meaning that the glycyrrhetinic acid binds in the kidneys and ultimately forces water and sodium reabsorption and then subsequent potassium excretion. And this, as a result, leads to hypokalemia. And then something I just wanted to note as well is glycyrrhizic acid, which is present in the natural and commonly used medicinal herb of licorice, which is what all natural licorice is made from. And in the body, this glycyrrhizic acid is broken down and then it turns into glycyrrhetinic acid. And then next slide, please. So I'm going to be talking also about some of the differential diagnoses that we came up with. And so initially, we came up with gastrointestinal potassium regulation, which is the loss of potassium due to elimination by the gastrointestinal and renal systems. And so the gastrointestinal loss was eliminated because there was no history of vomiting and or diarrhea or any surgical explanations for this. And so potassium loss must be renal in origin. And then secondly, the hyperanemic hyperaldosteronism. This is a ligand overstimulation for cortisol and aldosterone expressed by salt ion and water imbalance. And this diagnosis was eliminated due to no evidence of our patient having chronic heart failure, renal artery stenosis, or renin secreting tumors. And then thirdly, adrenal, medullary, and pituitary tumors, which is exhibited by excess corticosteroids in the body. But our patient had no evidence of adrenal, medullary, or pituitary tumors. And then next, digitalis, the mineralocorticoid and glucocorticoid excess by an ingested compound. But our patient has no prescription or presence of digitalis in the body. And we ruled out the genetic disorder HSD11B2, which is a genetic autosomal recessively inherited mutation. And this mutation typically arises in patients at a young age and causes severe hypertension and end organ issues. Rhabdomyolysis and renal failure can occur as a result of such enzymatic abnormalities. And although our patient presents with these conditions, he's middle-aged and such a genetic disorder arising this late in life with these symptoms is not typical. And so that's why we ruled that genetic disorder out. And after further testing, we were able to come up with a diagnosis, which will be talked more about by Dr. Kate in a minute. But with glycyrrhetinic acid, as I mentioned on the last slide, it has a direct effect on the mineralocorticoid receptor, which can procure apparent mineralocorticoid excess and raise the level of aldosterone. And so symptoms of increased circulatory aldosterone levels could cause hypokalemia, as mentioned before, and as well as metabolic alkalosis, arrhythmias, renal failure, and hypertension, which are all symptoms that our patient presents with. And so confirmed as glycyrrhetinic acid, and it has a long half-life, which additionally fits with the time frame, as that can take weeks for hypokalemia to dissipate. And additionally, our patient history states that he was consuming bags of all natural licorice. And so now I'm going to be passing off the presentation to Dr. Kate. Thank you, muted Kate.
Thank you. Sorry. So we know that the patient demonstrated hypokalemia, and hypokalemia causes rhabdomyolysis, which is when damaged muscle tissue releases its proteins, specifically myoglobin and electrolytes into the blood. And these substances can damage the heart and kidneys. And in this patient, this led to cardiac arrest, as the skeletal muscle is a very metabolically demanding tissue. And in order to meet that demand, it needs to have appropriate perfusion. When muscles contract, they may need a signal that's initiated by sodium, which shifts intracellularly. As it reaches a threshold, calcium enters to commit to a contraction, and potassium moves out. And during normal functioning, the local elevation in potassium usually causes vasodilation, which enhances regional blood flow. But if potassium is low in the blood, as in this situation of this patient, then the muscle cells don't release as much potassium as normal. This means that there isn't that vasodilation, and therefore there's not enough perfusion to meet the metabolic demands of the muscle tissue. And this causes ischemia, as the muscle tissue starts to necrose, resulting in rhabdomyolysis. And a common indicator of rhabdomyolysis are cramps in the calf muscles. And this patient did experience those cramps in his calf muscles, but they were overlooked as the occupation of a construction worker, as Dr. Spencer mentioned. So with this aberrant signal conduction in muscle tissue, the final part of it goes to the heart, as potassium is supposed to signal relaxation. But in hypokalemia, there is no relaxation signal to be sent to the muscle. And the heart is a muscle and cannot relax and starts beating in a way that's basically just shaking in place. And the heart no longer pumps blood anywhere. So overall, the pathological diagnosis was pseudohypoaldosteronism, which is a medical condition that mimics the effects of elevated aldosterone. This diagnosis is suggestive of the excess licorice consumption through the mechanism that Dr. Erin previously discussed. And this was complicated by cardiac arrest associated with ventricular fibrillation, which was the final diagnosis. Oops. As the patient's heart no longer pumps blood anywhere, no more blood is getting pumped to the patient's brain, which is why he lost consciousness and caused him to suddenly collapse. As minutes went by without blood circulation, his organs started to shut down. And as previously mentioned, emergency medical services personnel arrived and did what they could, and the patient was brought back to the hospital. After 12 hours in the hospital, the patient's potassium level was brought back up with IV potassium chloride. And after more medicine was given and multiple vasopressors were received, his blood pressure began to normalize. He was evaluated for ECMO, but it was determined that he was not a candidate because of his poor neurologic prognosis. He also began to have oliguria, which is the production of abnormally small amounts of urine, and this progressed to anuria, which is the failure of the kidneys to produce urine at all. And overall, because of his uneven pupils, as mentioned by Dr. Spencer, sluggish reactivity to light, and absent reflexes, the patient did not have a good neurological prognosis. Goals were discussed with his family, and they decided to focus on comfort measures. Therefore, the patient died with his family by his side 32 hours after his arrival to the hospital. We would like to note, or I would like to note, that the licorice candy that you usually buy in a store and consume does not contain the acid that is structured similar to aldosterone. Therefore, you can eat licorice candy, and that doesn't mean that you're in danger of cardiac arrest. But we do not recommend eating pounds and pounds of candy a day.
Wow.
Thank you very much.
Wow. That was a remarkable paper. Are there questions? Do people have any questions for the three of them? Well, if no one has any questions, I do. First of all,
Yes, sorry, I was just trying to find the unmute button. So basically, to sum it up, the patient was the licorice that caused his he was basically ingesting glycyrrhetinic acid, which acted on a specific pathway that presented the breakdown of cortisol, and that caused organ failure and damaged his heart, and that's why he died. I feel like that was a gross oversimplification, but I don't know.
In short, you could sum it up that way. The glyceride in the actual licorice, the active ingredient is glycyrrhizic acid, which in the body is broken down into glycyrrhetinic acid. Kate, would you mind going to the slide with the diagrams of the chemicals? And if you look in the middle left is glycyrrhetinic acid, and right above it is aldosterone and cortisol. If you can see the kind of conserved shape between the two of them with the ring structures, because of it, glycyrrhetinic acid is able to bind at the mineralocorticoid receptor, which is where aldosterone normally binds. And because it actually binds 100 times stronger. So what it does is it causes such a high amount of sodium and water reabsorption and such a strong amount of potassium excretion that there's such an extreme hypokalemia that it causes and partly leads to rhabdomyolysis, so muscle death, like we were talking about, which eventually damages the heart and causes fibrillation, leading to cardiac arrest.
Sorry, would you mind repeating that a little bit more slowly about the reabsorption?
Oh yeah, no problem.
Thank you, sorry.
So part of the, what that receptor does partly is control blood pressure, which is why we had initial blood pressure issues with this patient and had to use vasopressin and other vasopressors to control their blood pressure. And it also affects excretion of electrolytes and reabsorption of them. So in the kidneys where this exists, the sodium and water are reabsorbed from the body, so they're taken out of waste product, and potassium is put in place of it, which causes the hypokalemia, or the low presence of potassium in the blood. And since the heart needs the potassium to beat, as we know, it makes it difficult, and it goes to such an extent that it causes the heart to fibrillate or not beat correctly, and that leads to ventricular fibrillation and then cardiac arrest.
Awesome, thank you.
Thank you for the good question.
It's a remarkable story. I have a bunch of questions. I'm not going to ask them all because we don't have time for that, but I'll just ask one. Does this, first of all, was there any sign of emotional, or did this person have some sort of psychological issues, underlying psychological issues that would lead them to eat nothing but candy? Did the paper talk about all that? Like, why would this person do that?
From the history that we were able to obtain, there was nothing noted about any psychological conditions or mental conditions within the patient.
Yeah.
It was one of the things they did note as a problem in the case was the difficulty in history taking, which is often the case in a lot of medical cases, because people either have something that they're not willing to share or something that they feel embarrassed about. So it did take a number of hours after presentation for the family to eventually share that he had been eating a lot of candy, which possibly could have maybe made an effect on the ultimate prognosis. However, due to the neurological condition of the patient at presentation, it most likely wouldn't have made a difference.
Should this candy have a warning label on it? I mean, it literally killed this guy.
I believe it does. It's been used for a long time as a medicinal herb due to certain other properties, which I haven't looked into as much. And I believe it's a little harder to acquire in the United States, but I haven't done enough research to know if there's a warning or not. But I feel like that's something that if it doesn't exist, there definitely should be.
I read somewhere that the acid isn't in like the licorice candy that we buy in grocery stores anymore, because this is like a little bit of an older case, and that it was mentioned that they weren't sure where he got this candy, like with that much concentration. But it is, I think, sold in like medicinal shops and stuff like that. But it's not in the like Twizzlers or whatever. That
Right. I've eaten enough of those in my life to know that they're fine.
Yeah, I first read this, I was like, oh my gosh, I'm gonna die.
Yeah. Okay, I'd like to keep talking about it, but we can't, unfortunately. I'm sorry. Thank you. That was a great talk. Very, very interesting paper.